Good morning, everyone, and to anybody that is watching on YouTube, you are most welcome to our Health Committee. I will inform you that the most lively and entertaining, the highest rated committee at the County of Renfrew is, of course, the Health Committee. So welcome, of course, to all of you. I am calling the meeting to order. I will advise that the roll has been called and attendance taken. I would then move to item 3 on the agenda, the disclosure of pecuniary interest and the general nature thereof. The chair recognizes none. Thank you. With that, then, can I have a motion on the adoption of the minutes of our previous meeting, that is March 11th, 2020? Councillor Bennett, seconded by Councillor Grills. Any errors or omissions? I believe actually that I had identified a couple. Is that, I see Rose is here. I believe Diane also that I did spy your, I do see Diane Johnson on there. Yeah, I just noted a couple of small with respect to resolution number HC 20-0332, it said quality information programs and should instead say quality improvement. I had noted that the within both of the emergency services report and the long-term care report, it identifies that the reports themselves were attached as Appendix A. They are not, as everyone is quite aware. There are only 29 pages to today's report. The response to that, and confirm this if I'm mistaken, Rose, that we are working towards that, particularly as the new website will accommodate that, but because of the pandemic response and the training required to get that accommodated, we're still trailing. So I certainly recognize that, but it certainly would incorporate the change of the word information to improvement. So it will require an amendment then. So Councillors Bennett and Grills, would you be satisfied in continuing to move and second the motion if it were to be as amended?
Yeah, I'm in favor, Mike.
And Debbie Grills, thank you. Councillor Grills has identified the same. Are there any other errors or omissions to be incorporated? With that, then I will call the vote. All in favor? That is carried. Thank you. Then I will invite Chief Nolan, if you want to take us, please, through the Emergency Services Department report.
Great. Thank you, Mr. Chair, through you and to members of Health Committee. Item number 1 within today's Health Committee report is specific to our COVID-19 response and update for members of committee. I think the highlights related to the COVID-19 response, obviously, paramedics continue to provide 911 service in what are ever-changing times, both from a regulatory perspective, but also from a response perspective. We highlight much of the work related to the virtual triage and assessment center in item number 1, because I think it's really important that we remember why we set this up in the first place. And we know that there are many people in Renfrew County that don't have a primary care physician. And we know that during the pandemic, there was strong encouragement to stay home. So it seemed appropriate at the time, and I think in retrospect was appropriate at the time, that we provide people an option so that they can both stay home and continue to manage their health concerns, whether they be COVID related or not. And that meant if you didn't have a family physician, this, for many people, was the first time they were actually able to access a family physician through the virtual triage and assessment center. And if you did have a family physician, but were unable to get a hold of them, or you wanted advice as to whether you should be calling 911 or whether you should be going to the emergency department, this service also provided you that assurance to be able to navigate your health issues as well as the health system at the time, all with the goal of reducing the incidence of 911 calls and emergency department visits and or admissions by providing you an alternative to anything that we've done previously here in Renfrew County and in fact anywhere else that I'm aware of in Ontario. So by highlighting the role of the Virtual Triage and Assessment Center, I think that there are a number of components to that innovation that have been spoken of, such as access to family physicians, but there's also been considerable attention paid to the reasons that people have called the Virtual Triage and Assessment Center and things that may go beyond what a family physician is intended to provide through the VTAC, such as palliative care, such as more intensive acute care in your own home, such as access to specialists who are open during COVID-19 pandemic times, and being able to support professionals in their practice, such as being able to have emergency dental services available for people who may otherwise be going to the emergency department or have already tried, for example, a number of rounds of antibiotics or pain medications for a dental emergency. So I think that it's important that we understand it by design, and it's important to also acknowledge the role of the family health teams, the community health centers, the hospitals, the community and social services sector, and everything that envelops this entire model and allows it to work to its full potential. And I think Dr. Fitzsimon has a very meaningful quote on page 2 of today's report, where it says that our early results show that we're providing the right patients with the right care in the right moments that they need. And we often talk about that as being an indicator of efficiency, but I think it's also an indicator of performance as it relates to the VTAC model. There are a number of other quotes within the document, and one from Karen Simpson talking about how the health system came together across Renfrew County. And I can tell you that I've never been as inspired by seeing health professionals come together to just do what was right in the moment, and that also continues at this time. We also have a home care provider providing a quotation here about how it helped her client avoid unnecessary hospitalization and hours in the waiting room. And of course, from a paramedic perspective, one of the elements is the connection to the family health team, but it's also the registrar, if you will, for the swabbing that we've been doing in the community now for months. And I think, you know, it's important that while today we're focusing much of our efforts on pop-up sites for the public, if we go back to the origins of this, if you had a positive clinical presentation and a positive travel history, you would be assessed by a physician over the phone. Paramedics would be engaged. The paramedics would be going to your home to do a further clinical assessment and to do swabbing from start to finish. And I think that relationship has proven of significant benefit that is also within today's report as additional quotes to committee and hopefully to county council to be able to see the impact across the system. So the stakeholder engagement strategy continues. Public Works has been invaluable in getting roadside signage up to encourage people to use the VTAC. We also have worked very closely with the economic sector and Craig's team to make sure that businesses are helping us get the message out. And as we continue to resume society in a new way, I think it speaks to the nimbleness and the evolutionary role of the VTAC for the public. So now that we've moved into more pop-up assessment sites and now doubling back into long-term care to assist them and their staff in getting tested, I think it's important that VTAC continue. And you'll all recall, or many of you will recall at the last council meeting, I was provided direction to move forward to ensure that the VTAC model has the structure and has the wherewithal to live beyond the pandemic. And the warden and the chair have been extremely supportive in exploring various models by which that can occur. And there's further dialogue ongoing as it relates to the communication strategy and quantifying the important work that VTAC has already done with the over 5,000 people that have used VTAC in its short 2.5 months. So I think that that's very important work and will certainly be represented through the data, but I think that the testimonials that we've provided within today's report give you a bit of a spirit of what's going on out there. And I've heard from many of you on this committee as well, personal stories of your ratepayers and your residents who have used the service. And we're really happy to hear those, because as we get this sort of constellation of responses from the community, it allows us to adapt the service to make sure that nobody is left behind, that nobody is suffering in silence, and that everybody has access to family physicians and community paramedics 24/7 in Renfrew County. I think that that's very important as we move forward. Item number 2, Mr. Chair, is the static testing site. So as I previously spoke to, we have moved forward in 2-week increments of calendars, because we're still trying to understand where the province is at, or where the province is coming from in terms of the target and priority groups, where public health interests are, and how we are now engaging the public. And I would say overwhelmingly the response has been positive related to these testing sites, or these pop-up sites that are happening in 8 communities across the county. This week we started with slightly less frequency based upon the wave of people we received in the first 2 weeks. And I would say overall it's going quite well. And we're now doing Monday, Wednesday, Friday swabbing across the county. So kudos to public health, the paramedics, the family health teams, everybody that's throwing staff at making that possible. And it is a bit of a carnival where it's set it up, do it for 2 hours, tear it down, move to the next town, and over and over and over, Monday, Wednesday, Friday. And we've certainly heard, I've certainly heard in speaking with people on site, their appreciation for trying to get as much reach as we have within the county. And if we're not in your town on Wednesday, but it's important to you to get swabbing, well, at least you have an option to be able to drive 2 towns over, or 2 communities over, to be able to get that swabbing if that's the day that it's necessary for you. So we now know that with the resumption of some elective surgeries, surgeons are now requiring that people have a test within a certain time window to be eligible to come in for their surgery. So it's getting more and more complicated as we go, by our reliance upon the labs to be able to turn tests around in a timely way and be able to assist those components of the health system to resume elective surgery. So we'll keep a very close eye on that as it continues to evolve. Item number 3, Mr. Chair, is related to the County of Renfrew Paramedic Service Communications Strategy. And we wanted to put a little bit of, well, not a little bit, we wanted to put some structure and some priorities, and just share with committee what our goal is in terms of our strategic intent to deliver timely, consistent, effective, and professional communications with frontline staff, internal and external stakeholders. So we outlined that so that you can understand some of the method associated with our priorities and those key elements, obviously being the health and well-being of frontline staff and the public, providing information that's guided by the latest available evidence, provide information in a timely manner, communicate in a coordinated fashion, protecting patient confidentiality, and considering public perception of risk. And I think that we've all learned a lot in terms of the necessity for being very upfront and being very timely in our communications. We know that things aren't always perfect. We know that the evidence has been waxing and waning in terms of a number of components. You know, when do you wear a mask? When do you not wear a mask? When do you stay home? When are you allowed outside? What mask is good enough? What mask is not good enough? How are we to engage the public from an emergency perspective versus a preventative perspective? So I think we've all struggled with that, and the evidence continues to flex. We know that we saw the WHO come out this week and say, well, is it pre-symptomatic spread? Is it asymptomatic spread? Who's contagious? Who's not? It's imperfect times at best. But I think that if we can be consistent in the way that we communicate, hopefully that will assist the public and staff to be able to appreciate that, and also come to rely upon the fact that we're open and honest to say, based upon the best available evidence today, here's what we think. And tomorrow that may very well change, because the evidence will continue to evolve as the body of knowledge continues to grow. And our chair has been exceptionally good in terms of keeping his eye on the evidence as it flows by, as has my team. And we're often comparing notes to say, where are we at today? Because today is a very new day once again, and we can see that even in terms of conflicting messaging between local, regional, provincial, federal, WHO, and so on, it doesn't always line up. And that leaves us in a difficult spot, I think, as leaders in the community, but also as healthcare providers to be able to provide good advice. So kudos to Dr. Cushman for helping us wade through a lot of the noise related to the evidence and trying to come up with a consistent approach. And I would say that their communication lines up very, very closely with what I've put before you. Item number 4 is related to the ambulance service review. So this is our version of certification, and we're pleased to attach the certificate from the ministry attesting to our successful certification process. And in many years, this is one of the biggest things that we have to overcome in that year. And as you know, my team as a whole throws everything they have at it to make sure that it is as smooth an administrative process as possible and as fair and open and honest a process as possible when the province sends their team in to review our file. So congratulations to committee and council and City of Pembroke and the service as a whole for having achieved certification by the province. And it looks as though we'll be up for recertification in another 2 years. So it's a 3-year process and it takes about a year to catch up. So we'll be back at it again, but I think it's important just to acknowledge and accept that. The ministry does make some recommendations and observations, so we're wading through those as to be expected, and we'll continue to evolve the service as we go forward. Item number 5 is related to the public access defibrillator program and the AED registry. Very pleased to say that all of the recommendations that were in the Bill 141 are things that we are already doing within Renfrew County and have been doing since its inception. So the 351 active defibrillators in the county are all registered with dispatch. There's signage in place. The locations are clearly marked. And you'll recall that a year, maybe 2 years ago, Council had committed to continue with Rob Blackwell in the position of Public Access Coordinator. So he is the one that makes sure that your staff have access to all the most up-to-date information, pads, non-expired batteries, and so on. And Rob is doing an exceptional job at that and continues to also bring in additional funding for the program from our partners such as the Legion and other community groups that have supported us. So a big thank you to Rob and the community as a whole. So we are already compliant with something that is just enacted by the province. And then lastly, the Universal Influenza Immunization Program, and we've applied for and accepted to participate in this program for 2021. And once received, the vaccine will be stored. So as we've done in the past, we will vaccinate our own staff and assist public health where required to be able to provide vaccine to vulnerable populations, such as our community paramedic clients and anybody else within the community. It's going to be an interesting year for influenza to see where the second wave hits. So as we've done in the past, and much like what we're doing now, these past activities and partnerships with public health had allowed us to pivot very quickly towards testing for something that we've normally done in terms of vaccination in the fall. So I think that alignment has served us quite well in terms of our responsiveness towards COVID, and really a familiar stance in terms of us and the community paramedic program being already in the community, knowing who's vulnerable, and just engaging them in a new type of program, but not a new way of doing business, if you will, for the paramedic service. Happy to turn it back to you, Mr. Chair, and answer any questions about this or anything else that you'd like to discuss this morning.
Thank you very much, Chief Nolan, and I would be remiss at the outset right now if I didn't also acknowledge much appreciation to you joining us today. Mr. Morrow advises, I wasn't aware that the Chief of the Paramedics actually had vacation days, but apparently you are on vacation, so or pseudo vacation. So I must express my appreciation in our pandemic response for you joining us remotely today. I see from the background that you are not out on the water. I'm sure you are looking forward to that. With that, then, I'll go back to item number 1, committee. Any question, comment? I see first, Councillor Murphy.
Thank you, Mr. Chair. Through you to the Chief. I don't want to put you on the spot, but knowing that we want to keep this program, do we have an idea of the return on investment? What is it save? And I'm not expecting you to have these stats on you, but perhaps going forward, do we know what this is saving, the healthcare system, the emergency departments, that kind of thing? Because when you're talking about 5,000 people being assessed just in the county of Renfrew, that's a large portion of humans that are taking advantage of an amazing program. And that I've spoken before, that I've had a couple of friends use it. So I'm just wondering if that's something that you have an idea of, Chief.
Through you, Mr. Chair. So specific. To be frank, Councillor, I'm not going to answer that question today for you, because we've engaged Algonquin College to do a full statistical review of the program. That was originally to be presented to myself and the steering committee this morning. We've moved it to next Wednesday, and my intention is to give you more than the answer to that one question, but to be able to put it in context for you so that it makes sense through a number of lenses. I think, the notion of savings in healthcare is often a bit of a puka. It's sort of the, is it a true savings? Is it a cost deferment? Is it an access? Is it a performance? Is it, what is it? And I think that this is an important enough issue to give you a whole answer as opposed to any answer to your question at this time. So if you could allow me a few weeks to be able to fully contextualize that, we'll be sharing that with Health Committee and Council based upon the amazing work that I've had a preview of that Algonquin College is doing. And I think also importantly, as a third party, an objective third party, to be able to look at the program and be able to paint that picture in as full and a robust a way as possible.
That's awesome. Thank you.
Thank you. I believe that we will certainly grant that time frame, Chief Nolan. Any further items, questions, comments? Councillor Doncaster.
Thank you, Mr. Chair. So, yeah, basically on the same lines as that, and I think I've stated this in the past, that whether it's VTAC or Community Paramedics Program, we all recognize, or I believe we all recognize, the value of these programs. I think it's fair to say that we also recognize that whether, as the Chief just explained, whether it's either cost savings or cost transfer from one sector or one program to another program, these things, we need to be able to quantify these things. If there is a true savings for these programs in one sector or one program, I think it's important that we continue to lobby the province to acknowledge that and provide more funding for these programs. Some of the programs are funded at best at 50%. So as we continue, and there's lots of value, I'm very pleased with these programs, but we keep adding programs to our service at a 50% cost recovery or so. So I think that what the Chief just explained about evaluating the overall impact of those services is really important. Thank you.
Yes, and I will just one moment, Chief, because I'm sure that you can expand on mine. But of course, certainly much, if not all, of our community paramedicine, I believe, is funded at 100%. Those things that are outside of I guess, statutory obligations of our paramedic service through the Ambulance Act. It's my understanding that the community paramedicine that is outside of that funding model of the cost shared with the province. But Chief Nolan, maybe you can speak more directly to that.
Sure, I'd be happy to. And really, that was one of the points I wanted to make, because Councillor Doncaster is absolutely correct, and we have a keen eye towards ensuring maximum return on investment, if you will. We do receive the lion's share of the community paramedic funding at 100%. You may recall going back the better part of a decade, that council had committed to having 2 community paramedic response/first response units when the Whitewater through to Griffith issues had arisen. So there is that commitment at 50-50 or thereabouts as a council commitment. The balance of the remaining positions, which right now total 9, fully funded 100% through the VTAC, and an additional 3.5 positions are 100% funded through Ontario Health and formerly the LIN. And that has been our go forward position, that where we are adding service, that one of those conditions be that it be at 100% cost recovery. We've also looked at what would the future state of a VTAC mean in terms of volumes. We know that 9 includes the pop-up sites that we're doing, the long-term care component, many of the things that will likely not require durability at that volume. So we've estimated that an additional 2 community paramedics at 100% VTAC funding should suffice to be able to meet a projected demand related to orphan patients and after-hours service within the county. So there would be a blended model, as we've done in the past, because you may also recall that we received funding through HealthLinks for this funding, and there's discussions through Ontario Health Teams regarding additional funding. But I think what I'm most aware of is that these solutions need to be 100% provincially funded. So that is consistent with Councillor Doncaster's remarks. And we will not only quantify where the potential savings are within the system, but also what the impact is to the system and where there's a cost avoidance in terms of growth, particularly as it relates to the 911 side of the house, and the reductions in number of transfers to hospital as a result of services such as the VTAC, providing consultative services to paramedics in the home. Because while we may be saving other parts of the health system, we are also considerably saving ourselves in terms of pressures on growth to the 911 side of the house, which is entirely 50-50 funded, and considerably more expensive from a unit of service perspective. And I also want to reiterate that it is also a very valuable service that we need to protect, and providing community paramedicine, in fact, allows us to protect that valuable service of the 2 paramedics in an ambulance for the most critical patients who do need further care that we're not able to provide in the home.
Thank you, Chief Nolan. I believe Councillor Murphy, did I see your hand up again? Oh, sorry, I did not. I see from your shaking.
Sorry, I was just scratching the black fly bites on my neck. Sorry about that.
All right, thank you. VTAC number is available should they worsen.
Exactly.
I certainly want to echo, of course, very appropriate comments by Councillor Doncaster. We need to be very careful as some of the services that are in consideration are being delivered through VTAC currently, and hopefully in an enduring model such as this, that the healthcare system is entirely funded from the province and not through property taxes. So it is certainly something, a lens, if you will, Councillor Doncaster, that we will continue to view the advance of VTAC. Warden Robinson.
Thank you, Chair. Just to take people back from our County Council meeting, we have direction from County Council to do everything possible to continue VTAC post-pandemic. So at 4 o'clock today, a group of us will be meeting with MPP John Yakubuski to bring him up to speed on VTAC and our plans moving forward. We are going to do everything possible to maintain the system following the pandemic. You talk about 60% of the calls to VTAC being calls from unattached patients in our community. That's a lifeline that we've provided for the past 3 months. It's a silver lining to the pandemic. We can't allow that to be taken away. They have primary care access right now that they haven't had. Some people haven't had that in years. They've maybe gone to the ER or maybe not at all. So we have to do everything possible and to show the province that it is working, that it is an answer to a problem that's across the province of Ontario and actually across Canada, a lack of family physician access.
Thank you very much for that, Warden Robinson. Very timely. We will, of course, it is our intention to move heaven and earth for those that one person viewing right now on YouTube. You might see that I'm pretty buff as I begin to move heaven and earth towards ensuring that we continue to have this outstanding service for residents of our community. Anything further on item number 1, please? All right, thank you. Item number 2, please, the static testing sites. I see none. Picking up on the Chief's comments, of course, Councillor Riguer, one of the communities in your municipalities, Cobden, I did avail myself of that. And like the carnival, I did win a teddy bear because I got a ring to go over the top of the Coke bottle. Those are outstanding fundraisers that you're having as ancillary services at those, and it's outstanding the sanitizing that you're doing on that as well, Chief Nolan. Item number 3, County of Renfrew Paramedic Service Communication Strategy. I'm assuming also, Chief Nolan, Mr. Barber, the media relations and communications at the County of Renfrew has developed both the communications, the larger communication strategy, but of course the crisis communication plan and strategy, at which I believe each one of the departments has a participant in that. I'm assuming that this is certainly falling within the framework of the crisis communications. Is that correct?
Yeah, through you, Mr. Chair. To you, Mr. Chair. Yes, and I have to say, Carolyn McGrath, who's been seconded in the public information role, has worked very closely with Mr. Barber in his role, and it's been a quite exceptional collaboration between the two. So this lines up with the corporate communication strategy and lines up with and has the input of Mr. Barber, so that we are consistent, knowing that obviously we have a patient confidentiality component and things that may be more granular than that of a corporate comm strategy, but it is complementary.
Thank you very much. And again, echoing your comments, Chief, given essentially we're 6 months into this thing, and I get the complexity, of course, of a global pandemic, this seemingly once every century event. But I have been repeating ad nauseum, probably going back to when we were still in this chamber altogether, that I think our transparency and our communication is really the only currency that we really have with our community, because everyone is absolutely doing all that they can in the midst of this thing. And the decisions that we make today based on today's information are subject to change as that information evolves. And I know that the evolution of information, we are still in that dynamic that it could change day by day. But it's vitally important that we be transparent with the public. And again, I am going to acknowledge the outstanding contribution, certainly of the paramedics and the healthcare system as it relates to the County of Renfrew and the Township of the South Algonquin. I will certainly extend. But I think also, again, kudos to our population that have really buckled down and accepted the recommendations of all of the public health experts. The fact that we remain at 24 cases, I think, speaks volumes to the efforts of the wider population. So thank you for that. Item number 4, the Ministry Ambulance Service Review and Certification. I am just as pleased as chair at the certification, and I'm very pleased that we have another 3 years. Item 5, the Public Access Defibrillator Program and the registry. All right. Item 6, the Universal Influenza Immunization Program. I see, Chief Nolan, you believe you had your hand up.
If I could, Chair, in relation to this item, I don't have anything additional to add, but there is a contemporary issue related to masks and mask integrity within the community. So if you'll allow me, post 6, I wouldn't mind giving committee an update at your discretion.
I absolutely will. I'm fairly certain I have that discretion, Mr. Morrow, and even if I don't, I'm going to suggest that I do. On item number 6, I just wanted to say that I'm very pleased with item number 6. I don't think that these were, well, I believe item number 1 certainly was deserving of being item number 1. Outside of that, I don't think they are in particular order, but what I'm very pleased with as item number 6 is it is just another element with respect to recognition of what paramedics are and what they do and what they can do moving forward. So I'm very pleased it is yet one more stepping stone as we're crossing that Rubicon. So congratulations to the paramedic service for that. With that then, Mr. Morrow, so the verbal report vis-a-vis the question of the mask, is that going to be part of the report that we will accept after that presentation? All right, thank you. So with that then, Chief Nolan, I will hand it to you for a verbal addendum, which would be number 7, please.
Great, thank you. And I do appreciate that, Mr. Chair, in terms of the discretion to be able to do that, because there's an issue that arose late Friday that I just think it's important that committee is aware, but also because many of you are also delivering services, and this may in fact be an issue for yourselves as well. So hindsight is often 20/20, and when we look back to early March, you'll recall that prior to COVID being declared in Ontario, the paramedic standard, so it in some parts fits with number 4 in the Ministry Ambulance Service Review. The standard for paramedics since SARS, so going back over a decade, has always been that paramedics are fit tested annually for N95 use for any aerosolized or droplet or any infectious disease where there's a respiratory component, regardless of the IPAC standard. So IPAC being infection protection and control. So we have only stocked N95 masks and fit tested our staff to one predominant and one alternate size and type of mask that were all 3M and all widely available within the North American market. As you recall, back in February, March, when I had reported that those items had been on back order since January, so before COVID hit, North America at least, we had already had orders in for that same stock that we'd been using as per the ambulance service standards in Ontario. So when COVID came forward, the province made a change to the standard by which paramedics would use masks, which is different than the rest of the health system, in that most of the rest of the health system would normally follow the IPAC standards, which is a surgical mask for droplet precautions, N95 mask for aerosolized generating medical procedures. It was brought down that paramedics were no longer to wear N95s for all circumstances of infection control, but that they were to start to wear procedure or surgical masks for droplet only control and N95s only for aerosolized generating medical procedures. So we brought our Joint Health and Safety Committee to our command table in the early days to help us navigate these issues across the county. And I think that it's important for you to know that they've been a part of that. And this comes back to, what is expert opinion, what is evidence, what is available, what is not available. You'll recall that Health Canada, if you go to their website, has approved and disapproved and disallowed masks that have come in and out of the Canadian market in this time of austerity and in this time of fluctuating expectations around masks, especially for healthcare providers. So this isn't just a paramedic issue, it's a long-term care issue, it's a public health issue, it's a hospital issue, and right across the board. You'll also recall that we had asked for donations because the recommendations of the province at the time were that we need to start saving our N95s because they're going to figure out how to wash them, and we would be reusing N95s. So this is part of the 2020 remember when experience that we had. And at the same time, the province had also given, and the federal government had given special dispensation that paramedics could and should use expired N95s at the same time, because if that's all you had, then that would then be good enough. And one of the issues that they asked us to test on the expired N95s was the durability of the elastic. So, we're into some fuzzy science in terms of what's good enough, what's not good enough, some moving yardsticks over that same time period that has been a struggle for everyone, frankly. One of the challenges that we've run into with that is we are now testing the majority of our staff on somewhere between 7 and 9 different types of masks that we have in stock. And we are testing all of our staff on all of those masks, because at any given time, we only have some of this and some of that available to us in the workplace. So the provinces and the federal government is well aware of those challenges. We also know that this is going to become, I think, more acute as the other parts of the health system, whether that be dentistry, veterinary medicine, childcare, and so on, start to reopen, because there's now a renewed interest in getting various levels of masks in the hands of people so that they can reopen those components of society. The province has put a caveat to you're allowed to reopen if, but that if is that you have the necessary precautions in place, and those necessary precautions often, if not always, include a protective, personal protective equipment for both the workers and also, in many respects, the customers or the clients that are being served. So the issue that, now that you've got a bit of the background, the issue that popped up for us a few weeks ago was that we had a mask, surgical mask that we had received, and we've received masks from many different sources. We've received them from hospitals, we've received them from the province, we've received them from donations, we've gone out and procured masks, and we're still going through the process of where did we get which mask from, and when did it go out to staff, because none of the surgical or procedural masks are fit tested. I think that's an important thing for you to understand. Fit testing denotes that there's some form of seal to the mask, that when you're wearing it, it blocks out a certain amount of particulate. So when you're wearing a standard, surgical mask, we know that there's a pretty good barrier here, but there's no seal to your standard surgical mask that you wear. So surgical masks are not, upside down, surgical masks are not fit tested. And I think that's important, because we have as many different types of surgical masks as we do fit tested N95, KN95, and so on and so on. But all of the medical masks that come into the country are to be approved by Health Canada. And it's been pointed out to me that often the outside box will say not for medical use, so that it'll pass customs to be able to come into the country. And then the individual boxes within that box may or may not say for medical use. And so there's a lot of, let's say, gray in terms of how this whole issue is moving around. There are a number of other different stamps that are available, such as CE, CSA. You can probably see that CE stamp that's on here. So now we're trying to figure out, for masks that we've never carried before, what is an appropriate layer of filtration, for example? What is an appropriate mask in terms of water protectiveness? Is it sterile or non-sterile? So when you look at this one, it says that it's sterile, yet the masks themselves are not individually wrapped, maybe the package is. So these are the kinds of things that we all need to become more acutely aware of in our own workplaces, but also this has been an experiential learning for all of us when we look at how we're shifting with this, with our Joint Health and Safety Committee. So now that this bag is sterile, once the bag is open, of course, none of the contents are then sterile as you pull open those devices. So these masks, for example, that I've shown you are sterile, have a CE stamp, say they are for disposable medical mask issues. We had to pull from the road about 2 weeks ago because the elastics on the side of these masks very easily tear off. So paramedics were wearing them on calls, and when you put them on and the elastic breaks, It may have all of those assurances, but is junk, frankly, to us at that time. So what we ended up doing was pulling all of those based upon the experience the paramedics were having on the road. And we went to a different mask with a different elastic that does not have the CE stamp and was discovered later by staff. I'm even having trouble finding it now because it doesn't say medical on it. It certainly gives you the impression with the surgical mask and the cap and everything else that the individual is wearing on this device. They are virtually identical in terms of the packaging and everything else that goes along with it. But one of these boxes that look the same says up in the corner, non-medical. So when we get it in a case that may say medical on it, and then the individual boxes inside say non-medical, and we look at 3 layers of protection and so on and so on, it's been very difficult, frankly, for us to be able to interpret the standards. But good on one of the paramedics that brought this forward to us on Friday to say, did you know these masks that you've given us say non-medical on them? So immediately we said, okay, well, which mask do we have? Because we have all of these different boxes of masks in stock. And we said the only ones of everything that we have that actually say medical mask on them are the ones with the elastics that break. So you're damned if you do and you're damned if you don't. Excuse the term, but I think it's an important sort of expression as you are wading through these issues and we are wading through these issues. So what we did immediately was we pulled the ones that say non-medical with the very same concern for our staff and our patients. We notified public health and said, we need to go back and take a look at all of the paramedics that have worn these masks and who has had potential exposure, and how can we test these masks to see if there's any difference between any of these masks that we have, because the labeling and basically the market has been flooded by these masks over the last 3 months. In addition to that, we have received masks from the province. Again, all of these masks are brought into Canada based upon Health Canada approval, where there's a medical mask component. Other masks that we had ordered from the province are called KN95s. Looks like, sounds like, but isn't an N95. So what we did was we took a sampling of these KN95s. So you may see these types of masks floating around in the community. And what we did was we attempted to fit test staff on them. So you can actually get a seal, but it's not as good a seal as a normal N95. So this is what people would probably call knockoff masks, but they meet either a European or an Asian standard, not the N95, which is a North American standard as stamped by CSA or ASTM. So, but the elastics stay on. It's got a good nose bridge. It's not as good a fit. So what we've said to staff was, if you're more comfortable wearing this mask, which has a bit of a fit, we can do some fit testing, but doesn't meet the same requirements as the other. You're welcome to do that in lieu of these masks, which are more widely available, but far more circumspect in terms of their robustness for paramedic use. So what we did, and one of the other things I'll just point out for you, and in no way is this a comment regarding the language that it's written in, but the packaging is all in likely Mandarin. And so when we look at that and look at origin, we look at expiry date, we look at a number of different issues, this is what's been right across the system. I'm sure if you asked Shelley, if you asked public health, you asked many of our partners, what has your experience been? It's not been altogether that different than ours. But what we've done was we took the extra step with an abundance of caution by working with public health to say, let's identify all the paramedics that were wearing the one mask that very clearly does say, well, not very clearly, but does say non-medical up in the corner here. Let's do some contact tracing for the patients and see what the patient results have been. And all of the patient results were negative. So it's a non-exposure towards the paramedic. And we had begun testing our staff about 2 weeks ago, week and a half ago. Now we've escalated that with the support of public health to test all of the paramedics to make sure, again, out of an abundance of caution, that using these masks has not put them in a precarious situation. At the same time, public health has agreed that they're going through whatever means they have, be able to test those masks to see what the filtration rate is and see exactly what the net outcome is of whether it does or does not say medical on this box or the other box that it comes in. And we've pulled all of those masks. We've worked with the Ottawa Hospital and Pembroke Regional Hospital to try and identify other masks that may be available in the system that are superior to the ones with the elastics that break, also safe for medical use, and move those out to our staff as quickly as possible. So there's been quite a bit of interest in this issue. There was an update provided by Brian on Monday to the Emergency Operations Center. We've put this out to long-term care, to public health, and my understanding is that they have their own stories as it relates to masks. We've also put it out to the other paramedic services and the ministry themselves to let them know that in the supply chain, there are a significant number of masks that appear to be medical or don't say one way or the other, and to be cautious and conscious of that. So there's some public messaging, I think, that will be important out of this experience. We have had some discussions with media about this as well, because I think if there's an important story that there are masks in Canada that have possibly gotten by Health Canada and their approval process that don't meet our muster, such as the masks with the elastics that snap, that are not expired, that we can tell. Some of these don't have expiry dates on them at all. And we'll continue to work with our hospital partners, the province and the federal government to ensure that the appropriate level of mask is available as it was prior to COVID. And as the chair said, I have taken a bit of time off over the last few days because I feel as though we're in a window right now before things could possibly get much worse. So my caution to all of you is to try and catch that breath when you can. And I've said it on the EOC calls now for a number of weeks, because I think it's important that we take stock. We use the clarity of the retrospective view on how we got to where we are and what we can do better. We can do better on masks. We can do better on communicating that out amongst our partner organizations. And we're starting to receive similar feedback from our peers to say, yeah, we have the same issue. Thanks for pointing it out. And we'll continue to engage our unions and joint health and safety on evolving this issue in hopes that we don't have to wash and reuse N95s or use masks that are not appropriate in a medical environment, knowing that paramedics for the last almost 15 years have only ever worn an N95 for infection control. And I believe we need to look at how we get back to that state to provide them maximum protection as we go forward. So a very long addendum, I'm sorry, Mr. Chair, but I think an important story to understand from start to finish. And I'm happy to answer any questions that you are committing.
Thank you very much for that, Chief Nolan. I do note Mr. Beakley would like to comment on this. Also, just before I go to you, Mr. Beakley, I did want to comment. I think that was a very comprehensive report. Obviously, you have adapted to this medium because I was able to read each of those symbols. I will acknowledge the Mandarin did escape my comprehension. But all of the others I was able, and I think that certainly for the Health Committee, and I will note that our viewership has quadrupled when you began your address. It was 1, it is now 4. So I think certainly the ratings acknowledged Chief Nolan that that was a very comprehensive report. I know that it's out in the community, so certainly on behalf of the community, and I think also for staff across certainly all healthcare sectors, but in particular the paramedic service, that is reassuring to them. So thank you for that. Mr. Beakley.
Mr. Chair and members of the committee, if I could. So Mike, the only thing that I didn't hear was when the suspect masks were raised on Friday and over the weekend, we subsequently put them in front of the health unit to determine whether or not they were actually medical or surgical grade, and they weren't able to do that. And they have taken those masks now and they've run them up the chain of Ontario Health to verify whether or not those masks actually meet that standard. So it is possible it may come back confirming that they are the standard or not. Mike has erred on the side of safety in terms of removing and not using until we get that kind of confirmation. So just be aware that testing is being done through the health unit right up through to Ontario Health.
Thank you very much for the addition of that, Mr. Beakley. Committee, any question, comment? Actually, I believe I saw Ms. Sheedy. Did you have your hand up?
Sorry, I did, Mr. Chair. I just wanted to let committee know, as Chief Nolan had indicated, that this is likely impacting every healthcare organization in Ontario right now, but certainly our long-term care homes as well. So we've taken similar action. We've pulled any masks that are questionable. And we have provide a catalog of all surgical masks that we were using and provided that to the Emergency Operations Center for the province. And they are looking at them right now and are going to advise if they meet the standards. And as Mr. Beakley said, there's a good chance they may come back and say yes, even though there's conflicting information on them. But we've certainly erred on the side of caution. And in our consultation with the medical officer of health in terms of risk, really none, considering we've just finished surveillance testing of all of our residents. We continue to test symptomatically for residents. We're on our second wave of testing, surveillance testing of all staff. And as you know, all of those reports have come back negative from May through to the present day. And similarly, we have kept our residents, families, and staff, particularly the Joint Occupational Health and Safety Committees, well aware, and they're comfortable with the actions that we've taken. Thank you.
Thank you very much for that, Ms. Sheedy. And of course, early back in March and April, there were incredibly constrained inventories of PPE that I think has somewhat eased. But of course, and Chief Nolan, you had used the term earlier in the meeting of granular. So we're now at that granular stage, even with respect to the PPE. And identifying the larger packing box, the individually wrapped boxes, what kind of material is actually within these things. So as we continue to move forward, that has now become part of our processes. So we are, as I had indicated earlier, as more information comes to light, we refine our approaches. So once again, committee, Warden Robinson.
Thank you, Chair. And through you to Chief Nolan, I think it's important as well for you and for your staff and Shelley and her staff to know that we recognize the risks that our staff are taking day in and day out for more than 3 months now, being on the front lines, and any substandard equipment at all is unacceptable as far as we're concerned as a county council. I'll speak for county council on that. So thank you for your due diligence, and know that if we don't get the right equipment, then we can't do our job and we can't put people at risk.
Thank you, Warden. Anything further? Councillor Love.
Thank you, Chair. Most of us small municipalities also have staff who are on the front lines, and our municipalities are providing them with, and I'm not sure what grade of masks we're providing, but I don't think that our staff that are ordering the masks or getting them have any idea that it is as complicated as has been presented. And I do have a bit of a concern that we may inadvertently be providing our staff with protection that isn't sufficient protection, that it may be substandard. And I'm wondering if there's some way this information could be presented or sent to our municipal staff in a simple form, because I know it's a very complicated issue, but thinking in terms of the kind of masks that our landfill site attendants would be being provided with, just to ensure that we are providing a mask that is going to do the job. We're not giving them something that is not going to do the job. This has raised a big concern for me, and I'm going to go back and talk to my staff about it. But rather than have them starting to call county staff, if there was some way some information could be provided out to us to ensure that our municipal staff know what to look for when they're ordering masks. Thank you.
Thank you very much for that, Councillor Love, and for underscoring, of course, it had not occurred to me. I'm presuming that medical grade versus non-medical grade may have something to say on this, but I think that guidance that you're suggesting, perhaps Chief Nolan, if you wish to speak to that.
Yeah, I'd be happy to, and I appreciate the opportunity and the question, because I think that it's also a good time for a reminder that, you know, a mask is a mask is a mask, and it needs to be a part of an infection control program, right? And, you know, in many respects, that starts with 2-meter distancing, that starts with good hand washing, it starts with hygiene, it starts with avoiding situations where having to be within 2 meters of somebody is obligatory. In the economic sector, it's talking about plexiglass shields, it talks about shields, it talks about the gowns that we have, and so on and so on. So while much of today's discussion was about this mask versus that mask, I think that the guidance that we've provided our staff from the beginning is, you know, good education, good practices, being very consistent in the way that we approach and model that leadership, I think is important. And today, the fact we're doing a committee on a Zoom call is evidence of that unto itself. So none of us have to worry about which mask we're going to pick for this meeting. And I think that that's an important reminder. You know, we talk about having volunteers sewing masks and putting in coffee filters. And, you know, there's very little evidence out there that we could hang our hat on in terms of exactly what is appropriate. You know, is it 600 thread count? Is it 800 thread count? Is it this coffee filter, that coffee filter? Like, it just goes on. And I think we're all a little exhausted by it. But our commitment is to do a root cause analysis of this issue with our Joint Health and Safety Committee so that we can understand how we got to where we are. My instincts are, as I said at the beginning, we haven't ordered any of these things ever before. And now you enter that in a time when the consequence is that much greater. That's difficult from a quality assurance and a continued quality improvement perspective to be able to pick the right mask, buy the right mask, scrounge the right mask, receive it from an otherwise reliable source, such as a hospital or the ministry, or rely upon the federal government's inspection of these items as they're coming into the country. So we're always prepared to own our component of that. And when it was brought forward, we pulled it. Our only alternative at the time was the other mask that we had already pulled. And so then we defer to the KN95, you know, this coffee filter looking thing. And then we defer to the N95. We also have the PAPRs, the big hoods. So at all of our swabbing sites, the paramedics have been wearing that PAPR with the hood and the hose and the purified air respirators where they have consistent exposure by doing swabbing in the community. So that's not an issue in this play. And then we also have the C50 masks, which also have the chemical component, which our Sierra team have available to them. And it has a biochem filter available to it. Looks a little bit more like a Darth Vader kind of mask. And we've also gone to a 3M, looks like more of a dust filter with the bilateral screw-on filters for our staff. And as those are trickling in different sizes, we're issuing those out as part of our fit testing. So, you know, I'm not trying to complicate it for you or your staff, but specific to your question, I will share our root cause analysis in terms of what we've learned, what our recommendations are for our staff, and then encourage you to engage your respective health and safety organizations to be able to source the appropriate mask, put it in the context of a robust program. And as Dr. Cushman reminded our staff over the weekend, you know, and the chair earlier reminded, you know, we have had up to 24 cases within the county. Our incidence has remained low, despite the fact that paramedics have been involved in most of the swabs that have confirmed those cases. And we have yet to have a confirmed case within our paramedic community. And we have been swabbing our staff all along now for months. What we're doing now, much like Shelley has done with her staff, is we're going to be swabbing all of our staff, starting with those that are most likely to have had exposure, working our way through. And I've been swabbed twice myself as part of this process because I've been in and out of the workplace. And it's as much my concern that I keep my staff safe as understanding what my own exposures may have been in this process. So I'll be happy to share that with you, Mr. Chair.
Thank you for that, Chief Nolan. I'm going to go next to Deputy Chief Leahy. I think you wish to add something to this conversation.
Through your chair, thank you. And as Chief Nolan just touched on it, upon it just now, I think it's important to know that something that gave the staff comfort early days of this issue was that, keep in mind, and it's important for committee to understand, the masks in question today are our first layer of defense. They're the initial mask we're wearing in all patient care settings. However, we have full capability to up our game should a call evoke a requirement for something that is a little more proficient to the nature of the call. The face shields come down, the gowns go on, the N95s are available. As Chief Nolan just indicated, we have PAPRs, we have personal issued respirators as well. So these masks are the first line of defense for all calls. They're basically the masks you put on to have this conversation when social distancing doesn't take place. If there's any indication through the screening process that this may be a COVID suspect, the discretion and the opportunity is then with the medic to make the call on what other equipment they need, which, to be clear, they have availability to. Thank you, Chair.
Thank you very much, Deputy Chief Leahy. Mr. Beakley.
So if I could, Mr. Chair and members of committee, when this incident happened or arose on Friday evening, Paul assigned a working group to address this, and I was part of that working group. Coming out of that process, and specifically as it relates to the type of mask, I wanted to put Mayor Love's mind at ease. There are 3 thresholds: the N95, which is the primary mask, which is pretty much frontline workers. The second mask is the surgical or medical grade, which is also the frontline, whether that's long-term care or the paramedics, and then non-medical masks. So whether those are cloth masks that are made of the regular masks. I suspect that in most of your work environments, the masks that you're using, which are non-medical by nature, are satisfactory. And I can only validate this because we walked through this with Dr. Cushman to verify exactly what we were using and the level of comfort we had in terms of what we were doing within our own organization as it related to our current staff that weren't on the front line in either paramedics or in the long-term care center. So with some comfort, if they're wearing any kind of mask at all, you can have some assurance that they're wearing something that's protecting them to some degree, but it's only protecting them in the sense that they're not spreading, right? Because the reality is, as indicated from Mike, that you're in a scenario where if you're wearing those masks, you're only wearing them to protect others, not yourself necessarily. And that's the purpose of wearing those masks.
Thank you very much for that clarity as well, Mr. Beakley. So, committee, any further comments? I see none. So, can I have a motion to accept the what is it we call that, the Emergency Services Department report, please? Councillor Lafreniere, seconded by Councillor Reguer. All in favor? That is carried. Thank you. With that, then, bear with me again one moment, please. We will go directly into the long-term care report. Ms. Sheedy, please.
Thank you very much, Mr. Chair. Good morning, members of committee. The report starts on page 9 of your package. Items number 1 and 2 are the resident statistics for each of Bonnechere Manor and Miramichi Lodge as of the end of May 2020. You will note a low rate of our respite utilization, and just a reminder to committee that throughout COVID, the ministry has directed that respite beds not be used, that respite admissions not continue to occur. The other point that I wanted to make is you may recall that we are required to maintain a 97% occupancy rate year average, typically in order to receive 100% of the Ministry of Long-Term Care funding. However, the ministry did put out notice again early on at the beginning of COVID to identify that they are suspending the occupancy targets for the whole year 2020. Item number 3 is the wait list information for each of the 9 long-term care homes in Renfrew County as of the end of April. Item number 4 is our update on COVID as it relates to long-term care. So the update in terms of our residents and staff, as I've indicated to you before, we are constantly testing, and there's 2 types of testing. One is related to symptoms, and the range of symptoms for seniors in long-term care is quite broad. I've used the example previously that if a resident had a fall, that would prompt that person having a swab. And when that happens, then until those results come back, we treat that person as if they are a suspect case. So we wear full PPE with interacting and caring for that resident. So face shield, mask, gown, gloves. And so at any point in time, there's usually a resident or two in each of the homes that we are waiting for that swab result to come back. As of this morning, there's one at Bonashire Manor and two at Miramichi Lodge. Knock on wood, to date, all swabs that we've received for residents have been negative. For staff, as you know, we screen our residents twice a day as well, but we also screen the staff twice, one on entry and one on exit, take their temperature. They're provided with the PPE that we've reviewed, but we're also required, obviously they need to be tested if they have symptoms, but we also do surveillance or asymptomatic testing with them. You're aware we did 100% in May. And then on May 31st, the government directed that we repeat that twice in the month of June. And so both homes have finished the first wave of that in the month of June. Bonashire Manor is waiting on about 28 results of those to come back, and Miramichi Lodge, they just started theirs a little more recently, are waiting on about 146 of those to come back. Again, any that have come back have been negative. And then once that process is finished, we'll start it again to get completed before the end of June. The first bullet point on page 10 speaks to the Ontario Ombudsman investigation that is going to be taking place. But more recent news that came out post this report being provided to you was that on June 2nd, the Ontario Patient Ombudsman, so two different bodies, is also launching a systematic investigation into long-term care as it relates to COVID. And then I know you're fully aware through all of the media accounts of the investigation or commission that the province is taking as a result of the Canadian Armed Forces report. The top second bullet on the top of page 11 speaks to outdoor visiting. So committee is aware that through the provincial directive, we are not permitted to allow family visitors, what are called non-essential visitors in the home at this time. However, we can facilitate outdoor visits. You know, we were doing window visits and virtual visits, but now that the nicer weather is here, we wanted to offer this as another option to our residents and families. So I'm pleased to advise that just started this week. It is very labor intensive because we are exercising an abundance of caution in taking lots of steps to ensure everybody's safety. And we did run our plan by the health unit and they fully supported it and in fact passed it on to all the other long-term care homes in Renfrew County. So we are looking forward to the day when we can open our doors to families again. And as I indicated in Appendix 1 that was issued on May 29th from the government, they are signaling that they are looking at indoor visits right now. We don't have any details on that, but if like anything else during COVID, we'll probably find out on a Friday evening that it's effective immediately. So we are trying to get as prepared as we can behind the scenes for what that might look like. The final bullet point, or the last bullet point rather, on the bottom of page 11 speaks to the inspection teams that the government has utilized for the homes that have been identified as high risk, primarily through the military report as well as the infection inspections that have been happening by the local public health units. Turning over to page 12, the final two bullets, the second last one speaks to an article that was in the Ottawa Citizen where the journalist Ms. Payne referred to these issues that have taken the forefront of COVID as being the worst kept secret. And certainly since that time, the Registered Nurses Association of Ontario, RNAO, has put out a paper that references that there has been 2 decades of studies that have highlighted these risks and concerns. Equally disturbing, as noted in the final bullet point on page 12, is an interview through TV Ontario that speaks to the internal inspection system, and if those allegations are true, certainly very concerning with respect to our inspection system. Item number 5 is the resident co-payment rate. Committee would be aware that the province annually sets the accommodation or rent, if you will, rate that every resident across Ontario pays the same in every home, dependent upon whether your accommodations are basic or shared, semi-private or private. Typically, we are advised of those rates on June 1st and they're effective July 1st. On June 1st, the government advised that they were not going to put any increases in place until January 1st, 2021 related to COVID. This has no impact on our budget because whatever the residents pay is set by the ministry. If the ministry increases that, then the ministry reduces their funding to the homes. So it's a wash, so no financial impact. Item number 6, 2020 capital projects. I wanted to give you a heads up that related to COVID. I've met with the environmental services supervisors at each of the homes and reviewed our capital list that you approved through the budget process with the lens of COVID, because again, with respect to the restrictions related to essential visitors, knowing that we may not be able to go through with some of those planned projects. So I viewed them through a lens of risk to residents and or staff, and whether it would be safe to defer, because if we deem somebody to meet the criteria of an essential visitor, as long as we screen them and they wear appropriate PPE, we are permitted to allow them in the home. So with that, I won't go through each project, but just to overview that obviously if it's outdoor type of work like pavement and whatnot, that and our ongoing roof project at the Manor, that we can clearly go ahead with. Some things were started early in the year, right, following post-budget, so they were accomplished. At the Manor, you'll be familiar with the ongoing HVAC system. Basically, our system is undersized for our building. And you approved, this is the second phase now, you approved some money to be spent last year. We're on the second phase this year to enhance it. That is something that I have asked Mr. Norton to proceed with because there is a risk to our residents and certainly uncomfortable for our staff. We've already experienced when we had a heat wave last week, the building got quite uncomfortable and our humidity levels are very, very high. Similarly, at the lodge, again, if there's an outdoor project, it can go ahead. For the indoor projects, most of them were assessed as low risk at this time. However, the telephone system is one that you previously approved, and I think goes without saying we can't go without. And our current system is obsolete, and we are having significant problems with it. So that is proceeding. Item number 7 on page 13 is an update on our bargaining with the CUPE Miramichi Lodge Union. Committee will recall that on February the 6th, we met with our negotiation team and theirs. However, the union's proposal was cost prohibitive and quite frankly unreasonable. And for that reason, we had advised you then that we as the employer had told the unions that we needed to proceed with conciliation. We were that far apart. So that happened on May 28th virtually with conciliator Mr. Gagnon from the Ministry of Labor. I will provide you with more details of that in closed session, but I can tell you publicly that the following day, on May 29th, Mr. Gagnon advised us that the union had requested a no board report, which means the conciliation process is finished and the parties will go to arbitration. And then just an update on Bonnechere Manor CUPE. We did have some dates scheduled in March, but of course they were postponed related to COVID. And I will note that we are due to negotiate with ONA as well this year. Item number 8 on page 14, just a review and some information regarding the seniors housing strategy. You reviewed the issuing of a RFP through the budget process that has gone out last week with a goal to have a final report back to you by September 30th. The scope of the RFP is listed in the middle of page 8. Suffice it to say, it's not limited in any way to bricks and mortar, and we certainly want to take advantage of the excellent experience that we've had with VTAC through COVID and to see if there are any opportunities to consider it with respect to seniors housing options. Item number 9, Bonnechere Manor Seniors Care Without Walls. Committee will recall that we had to pause our adult day program at Bonnechere Manor, both the one here in the home and the one in Cobden, related to transportation issues, again related to COVID. We were keeping in touch with those clients on a regular basis through call-ins, but we were approached to start a program called Senior Centers, Without Walls, and that did start on June 1st. It's very low tech, again, just using the phone. And hopefully someday it will, expand to something more video related. But at this point in time, a lot of the services, programs rather, that we were providing, whether it was information, education, exercise programs, etc., are going on, believe it or not, over the phone. Item number 10 on the top, or all of page 15. We typically bring you expressions of gratitude, a representative letter that we would receive from a satisfied resident or family. Throughout COVID, the expressions have been nonstop, such that we've been posting them in our home for staff to see. So that's just a small smattering of them for both of the manor and the lodge on page 15. On page 11 is an update on fundraising. So suffice it to say, COVID has also significantly impacted fundraising, or certainly typical fundraising, because most of our initiatives involve large gatherings. However, you are aware of the Strides for Smiles program that went on throughout the month of May. And I have an update from the $5,200 that was raised as of yesterday morning. That's increased by $1,000, so it's up over $6,000. So that was a very fun and nice program and generated lots of positive responses. Item B is a nice alignment with our butterfly project. So we came up with the idea, lots of homes, Bonnechere Manor is one of them, that has a tree of life. Miramichi Lodge has something similar with the gold blocks in the fireplace lounge, where people pay an amount of money to have some sort of recognition that is posted in the home. So we had a local artist design glass butterflies for us, and the media release on page 20, I think, captures how beautiful they are, and the colors truly run the range of the rainbow. So for $100, we're going to put a wall covering up in each of the homes and hang these butterflies in the butterfly garden. So they will serve as a really nice piece of art as you enter into our butterfly units on each of our homes. And so that's had some really good uptake right off the get-go, and that started early in June as well. And then item C, Miramichi Lodge is also doing a virtual journey program similar to the Manors, but quite creative in opening it up to anybody to participate. And you can make any level of donation that you would like. If anybody has any questions on any of these, feel free to contact Lainey Bolt Johnson, and her information is on the middle of page 16. That brings us to resolutions on page 16, number 12. The first one, an unbudgeted capital equipment purchase request for Miramichi Lodge in the form of a carpet extractor. So the recommendation is that the Health Committee recommend the County Council approve approximately the $18,000 in savings from the phone system that I referred to earlier to fund the unbudgeted replacement of a carpet extractor, and further that the Finance and Admin Committee be so advised. So the background information on this is the carpet extractor is still a fair bit of carpet at Miramichi Lodge, and we've been using the same piece of equipment since the building opened 15 years ago. It has been repaired many, many times, but the machine itself has been discontinued. And so getting ongoing parts for it is going to be a challenge for us. The phone system you did approve through the budget process at $70,000. It surprisingly came in quite under budget at $30,000. You had already approved a portion of that savings being used to replace a dishwasher that was unplanned as well. So we're requesting to use the other $18,000 from this savings to fund, again, the unanticipated budget cost of this carpet extractor. Do you want me to stop there, Mr. Chair, or do you want me to finish with item number 13?
I think we'll go right through the report, please, Ms. Sheedy. So continue through 13, and then we'll go back to the start. And we will, of course, address each of number 12 and 13 separately.
Okay, thank you very much. So item number 13 is a bylaw on page 17 related to the Champlain Lynn and our service accountability agreements. So the recommendation reads that Health Committee recommend that County Council adopt a bylaw authorizing the warden and the chief administrative officer clerk to sign the extending letter for the extension of the service accountability agreements from June 30th, 2020 to March 31st, 2021 between the Champlain Lynn and the Corporation of the County of Renfrew, Bonnechere Manor, and Miramichi Lodge for the compliance with the Lynn Act 2006 for the submission by the deadline of June 26th, 2020. So the background is committee will recall that we have a number of service accountability agreements with the Lynn, depending if it's long-term care, it's called the LSAW. If it's a community program, it's called the MSAW. So again, related to COVID, the Lynn is requesting an extension letter that would typically have been renegotiated. I'm using air quotes because there's really no negotiation, but they could have some changes in it that would have been due in June to extend that deadline until March 31st, 2021. And the full information is attached in Appendix 3 on page 22 of your package. That concludes my report, Mr. Chair.
Thank you very much, Ms. Sheedy. We will then, committee, go back and go through these point by point. Information item number 1, the Manor resident statistics. Warden Robinson.
Thank you very much, Chair. So we all recall that I believe it was either the end of March, the beginning of April, the province stopped any long-term care admissions directly from hospitals. And then I believe it was the 24th of April that I wrote a letter to the minister and copied the premier and Mr. Yakubuski, indicating that it was our decision to discontinue any community-based admissions to our long-term care facilities, with the proviso that, of course, in extreme situations, Dr. Cushman would be involved, and we would also try to get support from our community paramedics for people staying at home. So I just note that under the Bonnechere Manor, it says there were 3 admissions in April. So I'm wondering, were those admissions, Shelley, community admissions prior to our policy?
That is correct, Madam Warden.
Thank you. Anything further on the Manor resident statistics? Moving on to item number 2, the Lodge resident statistics. Thank you. Item number 3, the Champlain Lynn waitlist information. Item 4, the pandemic update from long-term care. The only comment, sorry, I do see Councillor Murphy, please.
Thank you, Mr. Chair. Just through you to Shelley. When I was reviewing my report this weekend, when I got to the portion that you were doing outdoor visits, I actually exclaimed, "Oh my goodness, this is amazing news." And my husband said, "What's amazing news?" I'm just thinking in terms of watching these long-term care homes in our, especially in Toronto, and thinking, boy, this is something that should have been implemented for them months ago, not only for the well-being, knowing that your loved one is in a good place, but for the mental health aspect. So I applaud this, Shelley. I think it's wonderful. And if I had a relative in long-term care, this is exactly what I would want. So thank you.
Thank you very much for that, Councillor Murphy. And I too, when I was reviewing this, the note that I have in the margin that I'm looking at right now is very pleased to see this. Certainly on this overall report, and I think, sorry, this item number 4, I think probably Ms. Sheedy could have filled 20 pages with bullet points. Of course, long-term care has come to be the center of gravity, if you will, for COVID. Unfortunately, we've been very fortunate, and largely that is because of steps that were taken, both at our long-term care and the outstanding response from Dr. Cushman in the health unit. But I'm very pleased to see this. I know that there is certainly cited here in one of the bullet points is an article from Elizabeth Payne at the Ottawa Citizen. You may be aware there is certainly some chatter in the media on visitation in long-term care, but I think we need to be very careful as this has been the center of gravity or epicenter of certainly the most devastating impact of COVID-19. The decisions that were implemented that severely restricted family visits were certainly done for all of the right reasons, and I think we want to be very careful about revisionism on some of the steps that were taken. This was absolutely for the safety of residents and staff in our long-term care homes. Having said that, I am certainly enamored of the fact that this is outdoors. I think probably, given winter in Canada, that this was not likely something that was available to us prior to now, perhaps by a month or so. I also note that it is appropriate that should there be an outbreak status, this would be suspended, and remind committee again as soon as there is one person that is symptomatic, we are suspect outbreak, and one person to be confirmed with this is then an outbreak. It does not take anything more than one for it to be an outbreak. So I think that this is commensurate with how the province is phasing the reopening generally of our society and economy. I think it is appropriate from long-term care. With respect to the other bullet points, certainly the issues surrounding long-term care, the staffing challenges, the limited number of hours of care, that has been consistently addressed, as Ms. Sheedy has indicated here in her report, from the time of the Sharkey report. Most recently, even the Ontario Health Coalition had once again done that. I would certainly recommend the TV Ontario website, authored by the writer Matt Gurney, had a 4-part series on long-term care that was also outstanding. In all of this, the article from TVO regarding the disturbing insights, there is a lot of things to become quite animated that we've discovered or have known for some time in long-term care, but the allegations that are certainly made in that TVO interview with respect to an inspector, which is, and there is no way of terming it anything other outside of malfeasance within inspections and the inspection protocol and regime, in the province. These must be thoroughly investigated, these allegations, and if they are of substance, they are enormously disturbing with respect to inspections of our homes. So with that, anything further on 4? Item 5, the co-payment. Item 6, the capital projects. I think, again, the criteria, Ms. Sheedy, was very well considered as to not exposing any high risk to any of the residents, of recognizing the need for capital upgrades at both the lodge and at the manor. Item number 7. Item number 8, the seniors housing strategy. I just wish to comment that in the midst of this unprecedented challenge, this incredible disruption to every facet of our society and civilization right now, I certainly want to acknowledge the efforts towards working towards this, the housing strategy and how we fit in. I don't believe that it is a secret whatsoever that bricks and mortar long-term care is not possibly going to accommodate the wave of population demographic that is going to require long-term care moving into the future. So I think that certainly need to acknowledge and commend Ms. Sheedy on continuing forward with the housing strategy. Bonnechere Manor's care without walls. Again, an outstanding initiative of seeking a return of something that is akin to normalcy at the very least. Item 10, the expressions of gratitude. Item 11, fundraising. All of these are outstanding, and certainly through you, Ms. Sheedy, particularly in that we are in lockdown. I would very much like to make the acquaintance of Mr. Irving. I think that this was an outstanding initiative at the manor, and likewise the enormity of the response. Once again, speaking volumes to the generosity of our community. With respect to B, also, I have been in contact. I think that this is a very innovative, very creative fundraising initiative, and I look forward to participating both at the lodge and in the manor with a butterfly. All right, resolutions. Can I have a motion on item number 12, please? Councillor Murphy, seconded by Councillor Love. Any discussion, comment on the carpet extractor? I see none. Certainly, I am very much enamored of the fact that we saved a significant amount of money on our telephone system, that it has afforded us opportunity on 2 different items to make significant headway for some unbudgeted items. So outstanding to have been able to do that. With that, then, all in favor? That is carried. Thank you. And finally, bylaws. Can I have a mover, please, on the Champlain Service Accountability Agreement? Councillor Regier has moved. Councillor Doncaster is seconding. Any comment, question? I see none. All in favor? That is carried likewise. Thank you very much, committee. With that, then, can I have a motion to accept the long-term care report, please? Councillor Murphy, seconded by Councillor Bennett. Any further discussion, comment? All in favor, then? That is carried likewise. Thank you. Just bear with me one moment, committee, while I pull up my agenda once again. Administration Department report. There is none at the time of mailing. Board of Health minutes. You will note there is a link there that will take you to a page. It actually looks like, and each of you should be familiar with what looks like a ballot from a municipal election, and I believe it is the 4th or 5th choice downwards. You can there avail yourselves of all of the minutes. I think that the last ones that we saw perhaps were at our February Health Committee meeting, that were from October 29th, so they have become somewhat stale dated, but I believe that these will catch you up significantly, so I encourage all of committee to review those through those links. Is there any new business? Thank you. I do note that we have a closed meeting, so I'm not sure who is going to continue to be participating in this, Mr. Morrow. Prior to that, we are now an hour and 45 minutes into this meeting. Does anyone need to take a 5-minute washroom break? I see a few hands have gone up. So I certainly will accommodate those. I think that we do not need to have an uncomfortable committee as we are engaging in this conversation. So we will, it is 11:11 by my clock on the computer. So we will take to 11:20 and then resume for our closed session, please.